You're listening to Physio Natters, this month in association with Choose Health, and this is session 2. Welcome back to Physio Natters. I am Jack March, and this month we're going to try and resolve a current, long-standing, hard-fought, friendship-destroying question. Where on earth, if anywhere, do adjuncts fit into modern therapy and healthcare? To help me try and elicit some useful conclusions and resurrect something from the argument fallout that we've seen across social media, I've asked my favourite Geordie to come on to Physio Natters and share his thoughts. Unfortunately, Alan Shearer wasn't available, so I had to ask Rob Tyer. We have for a long time been trying to get someone to come on to the Physio Natters podcast and discuss adjuncts in a favourable light. Acupuncture, therapeutic footwear and core stability were all podcasts in the pipeline, however these were shelved at the last minute. So for those of you requesting these podcasts, we have done our best to bring them to you in the most balanced way we can, but so far we have failed. As a result, Rob and I are going to discuss adjuncts in general, where they fit in current healthcare models, their utility and potential pitfalls. Mr. Chu himself wanted to come on this episode, but with only 20 minutes to play with, we decided to keep him onto the longer Physio Matters podcast for now, where it's easier to edit his waffling. See you on the other side. Rob, welcome to Physio Natters. We're gonna solve the age-old problem of adjuncts today. I hope you've brought your A game.
Yeah, every day is an A game.
Okay, right. I'm gonna get you with a non-fence-sitting question to begin with. You ready?
Yeah, no problem.
Okie doke. Right. All therapists use adjuncts in one guise or another. Exercise, for example, is an adjunct in some scenarios. So, do adjuncts have a role in modern healthcare models? Yes or no?
I suppose if you were going to pin me into a corner, it would have to be yes. But it would probably need expanding upon, and I suppose this is the best format for that, considering this episode's about adjuncts.
Adjunctivitis.
Yeah, adjunctivitis, yeah.
I really like it.
Yeah. I suppose the first thing I would say is, what do we consider as a core treatment? And I don't mean that in the term of treating lower back pain, core treatment.
You mean a bit of Pilates?
Yeah, a bit of Pilates and tying a string around your waist.
That's always good.
So what do you think, if someone was to say to you a core treatment is, how would you define that?
Well, I think I would go to some of the literature about OA and some other conditions and say probably what would be considered our core treatments would be exercise and education. However, in various contexts, I think you could argue that they are adjuncts in the same degree as anything else that we might apply, manual therapy, acupuncture, etc., etc. So, again, I don't think it's a dichotomous answer, which is where I think you're trying to get away from saying yes or no, aren't you?
Yeah, I'm a bit, if I'm honest. It's one of those ones where I've often been accused of being a fence sitter, but I don't like to put all my eggs in one basket.
No, we need them sometimes, I think, but hopefully we'll try and sort that out in this episode, shall we?
Yeah, give that a go anyway. So for me, a core treatment, I suppose, would be one that is, it's defined as one that is applied to every person that comes in with condition X. One that is a necessary treatment that should be applied to everybody with this particular condition, and without which we can't move forward.
Yeah. So different core treatments for different conditions.
Horses for courses. And then I suppose as an extension of that, an adjunct would be one that is not necessarily needed with every single person with condition X in order for them to improve, but one that could be applied at the discretion of the treating therapist on the premise that it does no harm and that it has some demonstrable beneficial effects.
No, I like that. I think with some clinical reasoning thrown in as well, I think that's not too bad.
Yeah, I don't see what all the palaver's about. We've sorted it out.
Oh, well, should we end there?
Yeah.
Okay. I don't think anybody's going to be happy with that. Right,
no.
Okay.
I know one person who won't be anyway.
No, well, exactly. So, one of the things that I think we should mention straight away is the reason for this episode. So, I have a bit of a problem at the moment in that I think we are debating adjuncts to the nth degree when actually we've got bigger fish to fry. So, I know that, let's take manual therapy, for example. I mean, I get that it shouldn't be overused. Potentially it can create dependence, fragility, reduce self-efficacy, would be some arguments that would be made. And then in the other corner, people would say, oh, it's not doing any harm. What's the matter if we're using it? Or even further, that it works absolutely brilliantly for an absolute ton of conditions. I mean, from my point of view, it's just a bit of laying some hands on someone, giving them a bit of reassurance, sometimes, reassuring touch. I think we're overthinking it a bit. Do you reckon that? Or what would be your thoughts on there?
I think you would, in my opinion, be spot on with the overthinking thing. I know certain schools of thought are that, the specificity of this particular laying on of hands has this specific effect to this joint or that piece of soft tissue, when realistically I think what it serves to do is almost a therapeutic distraction, a bit of reassurance, non-verbal reassurance, guidance, because I would consider if someone had difficulty squatting, we'd use my hands on their upper back to help them, or their knee, or to help guide them through the movement to demonstrate that they're not fragile, they just need a little bit of guidance into an avenue that they haven't explored.
Yeah, a bit of feedback goes a long way sometimes, doesn't it?
Definitely.
And I think there's lots of other things that you could, again, we could debate to the nth degree what constitutes manual therapy almost, couldn't you? I mean, I do plenty of things that I would consider attempting to symptom modify people, scapular facilitation or whatever it might be. And then you sort of go, well, okay, well, if I'm not going to do that, we can bring up a false dichotomy, really, couldn't we? And I think this gets thrown around by both sides. But sides, it sounds like it's some sort of contest, doesn't it?
But almost is, though, when you've got something like a Twitter feed which has got such a small amount of characters. You almost have to boil it down to a black and white yes and no answer. That's not the case, or is it?
No, and I think both sides annoy me.
yeah, definitely.
Why can't we use a bit of it sometimes? Anyway, we can get to that later. But I think, we've got bigger fish to fry than this. I mean, we mentioned before we came on air, sounds again like we're a bit live, but we mentioned before, you see things in a lot of physiotherapy literature, dare I say even the CSP with Frontline advocating courses for, energy medicine, things that, from my eyes, unless someone else has got some scientific reason that I'm wrong, but that don't even have any biological plausibility at all. And I just think maybe we should try and eradicate that kind of stuff. Adam Meekins would call it woo, wouldn't he?
I don't buy the whole do no harm thing from that perspective as well. Because I think the definition of harm could extend to that of the taxpayer.
Yes.
Could extend to that of the psychological well-being of the person who's receiving that treatment in place of something which has been demonstrated to have higher efficacy.
Yeah. And it's time as well, isn't it? Like you say with the taxpayer, if you're doing X, Y, and Z treatment, and you've only got a 20-minute or a 30-minute appointment, and you're, dare I say, wasting 10 minutes of it doing something that has no evidence behind it, never mind a small amount, or you're doing something which others would consider completely implausible, then what's that 10 minutes achieving, even if you do something, even if the patient does feel a little bit better afterwards?
The ritualistic nature of some of these things, like, I don't want to pick on any particular style, but things like acupuncture, bowing, where, unless I'm happy to be corrected on social media, but I've been informed that the therapist has to leave the room in between treating different parts of the body.
Yeah.
Or with the acupuncture, it has to be prepared in a certain way. And you could even argue with an injection, you got your big purple spray that you use to clean the skin, put the gloves on, wash your hands, all that jazz. There is a lot of theatre behind everything we do.
There is. And even down to, I suppose you could argue the same way things about exercise. And you mentioned about specificity of manual therapy, for example. And I think sometimes we apply or advocate some exercises for a reason. Maybe, like you said, squats. Maybe we're advocating squats for mobility of the lumbar spine or strength of glutes or whatever. And actually, how specific are we being with those? People are amazingly able to compensate for issues that they might have or weaknesses that they might have. So why wouldn't they do that during a squat, even if they have a good
post hoc argument of,
yeah.
well, if we change the way you squat and it changes your pain, then that must have been the reason why you had the pain.
Exactly.
Actually, we don't know whether they've always squatted like that.
Yeah, exactly. And also, we don't know whether they're squatting like that, or even down to running or walking in the clinic like that because they're being watched. Yeah. And also, we talk about, I talk to some of my patients about being sort of over vigilant towards their back or their knee or whatever body part might be painful, and that they are not consciously but subconsciously avoiding using that area of the body in sort of a free way. And then I think to myself, well, actually, am I just making that worse because I'm pointing that out? And then that's almost the same for an exercise as well. In some way, you go, oh, your shoulder stabilizing muscles, the rotator cuff, they're weak, so we're going to give you some strengthening exercises. And then the patient goes away and goes, my shoulder's going to be less stable because I need strengthening exercises.
It's an oversimplification of a complex condition.
And I think when you see the two sides of the argument about manual therapy, I go, you could apply this to any adjunct or any form of treatment, and actually, is this helpful, this sort of dichotomous argument? And I understand what you mean about the Twitter and the reduced number of characters that you can use, but sometimes I sit there and I'm reading these long streams of hundreds of replies, and they're battering each other, and I go, poor, not mention us, but students, new grads, they learn all these skills and these things in university, and they come out and they go, they go into a workplace, and I'm arguing with one of my colleagues about what the specificity of their treatment is that they're doing, or they go onto social media and they see the same thing, and they go, well, where do I go from here? What do I sit? Where do I sit in this argument? They haven't done the reading or haven't had the exposure to the evidence for as long as some other people, and I think there's going to be some dissatisfaction in that. I think.
Do we have to give people some tools to go into the workplace with?
Of course,
in order to cope.
Yeah, and we don't batter other things quite so much. Like we said about people doing treatments that they shouldn't be doing or aren't necessarily advocated, and that isn't as vilified, I don't think, as maybe it should be. And again, like you say, maybe we should be called out on social media for saying things like that. But that's my opinion at the moment. I just think that we're debating manual therapy. Manual therapy is the one, isn't it? I mean, that really gets people going. You've got one side.
It does take a hammering.
It does, doesn't it? You've got one side who hate it being called an adjunct because it's another tool in the toolbox, and we all hate that phrase. And then you've got the pro side, and they hate it being called an adjunct because that's by definition something that's inferior. And so no one likes the word adjunct, and then it gets thrown around like some sort of swear word, and it's just...
Yeah, it's hard to accept something being called an adjunct when you've spent thousands of pounds postgraduately developing that adjunct.
Yes, that is a very good point. And I just find the whole thing is getting a bit grating, really.
I wonder how much patients see of this as well, with a lot of them being social media savvy. Yeah,
exactly. One of my patients the other day told me, my blog that I write, told me I should write them more often, and I thought, oh my God, they're actually reading it.
At least someone is.
At least, that's my one reader, yeah.
Speaking of blogs, I must say, I've been reading with great interest Neil Maltby's Becoming More Human blog with great interest.
If you're going to read one blog, it's got to be that one.
Yeah. I think one of the things would be worth reading is this sort of. I think the title is Regression to the Shmeen, or something along those lines. It was a play on words of regression to the mean, and it's one thing that sort of made me reflect on how often I use that as a counter argument to my peers and colleagues, and think actually maybe I'm being a little bit too militant with it. I need to think critically about what I mean by when I say regression to the mean.
And I think, and what I particularly like about Neil's blog, getting right off topic, is remembering that actually there is a human being on the end of what we're doing and the end of these arguments that we're having. And actually, something that you pointed out, and I think you pointed out in Physio Natters, the most recent one, session 27, we shouldn't be punishing people who come in with pain. And I know that I'll get you to talk about your thoughts on pain in a second, but, if someone comes in and they're obviously struggling, they're obviously suffering with pain, and we've got a tool or a mechanism of reducing that down, even if it is short term, then I think that's a perfectly acceptable thing to do, as long as they're not a particularly addictive personality, and that's difficult to pick up, admittedly, and they haven't had lots and lots of therapy input before. They don't have those seeking behaviours that might lead them to get the wrong impression. I think it's perfectly acceptable to do in we're going to use the word the buzzword, but in the right context.
Yeah, and that just makes things really great, doesn't it? And I would hate for it to be a license for people to be mavericks and do what they want and say, but it's within the context of this patient's journey.
N equals 1 doesn't mean do whatever the hell you like.
It doesn't, and I'm sure we'll find that out when we go to the Course Health conference in May.
Yeah. We're going to plug everybody else's work, aren't we?
Yeah, I suppose. Why not?
Good idea.
Why not? It would be nice to have it reciprocated as well, though. Neil, Maltby, Roger Kerry, please take note.
So, Rob, you've got an interesting point around pain. So,
yeah, I thought we kind of talked about this off air, I suppose, but
yeah,
one of the things I was thinking is that when we're looking into research of pain, are we lumping in pain with suffering? Because I don't think the two are mutually exclusive. I think you can have high amounts of pain, but not necessarily be suffering a lot at that stage. And I think the clue's in the name, we are healthcare providers at the end of the day, and we can dish out all the advice and, reassurance in the world, but sometimes patients aren't bothered about that, and they just want to feel better. And to use your buzzword of the context again, I suppose it has to be framed within a legitimate context as to how we're going to go about dealing this, because I would hate for us to fall into that trap of the arbitrary 4 to 6 sessions of intervention X in order for us to see whether someone's getting better, when effectively what I think that is doing is just treading water until the patient recovers anyway, and has a secondary negative effect of creating something like a dependency. And I put that up when we were talking about this, when we were prepping it, about creating dependencies versus creating independent problem solvers, and I think we'd all like to think we are creating independent problem solvers, but if we reflect hard, I don't know if we're doing that with everybody. So to go back to that point would be, if somebody's coming in and they are suffering rather than their main problem is pain, should we be then taking steps to alleviate suffering in a legitimate context of healthcare provision and in a way that reduces the dependency and framed in a way, and this sounds like gold standard treatment, and I wouldn't like to say that I'm doing this perfectly, but framed in a way that we are allowing them to explore a variety of movements, including those ones which we apply to them, so physiological movements, accessory movements, as well as the physiological movements, to give them options for movement, because obviously movement is medicine, and I think that's something that we would all agree on, is that is the main aim, is we've got to get people moving.
Definitely, and I think, again, something we've chatted about before is, I certainly know that I do it, if you're having a bad day, have a few paracetamol, take the dose, make yourself feel a little bit easier so that you can carry on. That's no different, in my eyes. Yeah,
and a lot of people are very averse to taking chemicals, and because people are averse to taking tablets and rather would have something passively done to them. But I suppose that is another mechanism of offloading responsibility to somebody else to look after your care. And I think I've had a discussion with a few people on forums about the negative consequences of taking chemicals for pain versus things like massage. And there's a lot of people banging the drum for manual therapy, including massage, in place of things like analgesics because of the negative effects. And then it got into sort of the whole debacle of, in inverted commas, big pharma. And it just got off topic. But I think they were quoting figures about how there are a lot more risks of death with ibuprofen use than there are with spinal manipulation. I questioned that because they were giving me raw data, and I wanted to know if there was a relative statistical a percentage number.
Yeah.
Because you're going to get more people taking ibuprofen than you are receiving manual therapy.
You would assume so, yeah.
Yeah, so it's a difficult one. I don't think we've got the answers. at this stage with chemicals versus manual therapy, but I certainly think we've got to give people that ability to take control of their own pain. And if they have to reach to the medicine cabinet and go, well, I know that this is effective to get me through my shift at work, then I'm going to do it temporarily until this settles down. Rob and Jack have said that this is going to get better, so I trust them. Let's crack on.
Exactly. And I think, all of these things, it's no different to the exercises. I've had conversations about with people or before about, do we wean people off their exercises? Because I do often try and say, oh, well, look, your shoulder pain's resolved, so actually you don't necessarily need to be continuing with these exercises because you're now functionally capable, and that will maintain your muscle strength as long as nothing massively goes wrong. So, why don't you try, instead of doing it 5 times a week, drop to 4 for a couple of weeks, then 3, then 2, and, if your symptoms come back, then fine, maybe you do need a maintenance dose for three times a week, but if it doesn't come back, at least in the future you've got those exercises somewhere hidden in a cupboard, or you remember that those exercises worked before, and maybe you need a refresher, so you can give a quick ring, and I'll post you them out again or something. And that can be quite a good thing to try and wean them off, so they don't have that dependency even on exercise. And I don't think anybody would say that exercises particularly have a poor side effect, other than maybe what I said before about increasing vigilance or something if you aren't careful. But we've got to do something at some point.
Yeah, I think to sort of be the bad guy on that, and because some people do use that as a defence of certain practices, like the arbitrary application of 4 to 6 sessions of whatever treatment. We've got to be seen to be doing something. The patient walks away and say, well, you didn't even do anything, or all I received was exercise. I think that just demonstrates lazy application of care in therapy, because it's not the patient obviously hasn't recognised that there is an ulterior motive for this to help them get better. They believe they've come into the department wanting to have exercise, wanting to have treatment, or whatever it might be. And I think we have to sort of do a hat tip to Mike Stewart. It's very, very important with our communication strategy. So are we framing this in a way that the patient takes away and understands it? Are we doing the Kieran O'Sullivan test of, well, what have you taken away from today's session?
Yeah, for sure. I think that's a good way of doing it, isn't it? And we've all had those patients that come in who have seen another physio, and they go, oh, I went to the physio and I had four sessions, and they did some manual therapy or whatever they say it was. They did some massage and gave me a sheet of exercises, and I went away and it was okay for a bit, but then it all came back. And you can it's very easy to go, oh, well, that physio was terrible then, weren't they? Because they just shoved some exercises under your nose. But it's like you say, it's the perception of what the patient is receiving, or what the person is receiving is very important. So if they're putting more weight into what you've done with your hands than maybe you only spent 2 minutes or 5 minutes of your half an hour with your hands on them, but they've applied more weight to that in their context. So you've got to be careful with that. And I try very hard. Sometimes I fail, but I try very hard not to belittle other professionals when they've done things, because who's to say that my patients aren't going away and saying that to someone else? I don't know that.
Well, exactly. I've done my fair share in the past of things like GP bashing and therapist bashing, and you have to reflect and say, well, they wouldn't be coming to you if they were better. So you're only ever going to get a negative cohort of people. I think the therapeutic relationship goes a long way as well, and I've often had people who've no doubt said this to other people about me, but when they've come in and said, I just didn't really get on with that other guy, or I feel like I can talk to you. So you've got to kind of use that and run with it, haven't you? I think you mentioned the word reassuring touch, I think, before. That's incredibly helpful, whether it be a handshake on first meeting, or a hand on the shoulder as someone's getting upset, or guided squat, or guided reach with the scapular facilitation. That therapeutic touch and reassurance, that almost unwritten, unspoken of, it's all right, I've got you. Yeah, we can move, it's fine. Rather than, you see, I've applied this ancient Chinese secret of a C01 manip or something along those lines, and that's improved your hamstring tear that you had.
I don't want to stop people from doing the adjunct therapies. I want to stop them from doing some adjunct therapies, don't get me wrong, but I think we need to be discerning with their use. I often find myself sometimes applying some manual therapy because because of the patients that I work with and their long-term conditions, especially in rheumatology, with AS patients with a fused spine, sometimes I will give them massage if they are really craving it. I remember one chap specifically really craved or was really requesting massage, and in the end I sort of felt, well, at least if I do it, I know I've seen his MRI, I know he's completely fused, I know that what I'm going to do is going to be safe, whereas if he goes out and he goes anywhere else that might not
ask the questions.
Exactly, and then I think, well, actually, it's probably safer in my hands than it is in somebody else's. Well,
yeah.
So that's not fair. Into someone who doesn't know about the condition. So
no, I think it is fair. I mean, I was having a discussion with the rugby doc yesterday when we were on pitch side, and he's an A&E doc, and he has the same difficulty when someone rocks up off the street and he asks them if they got any medical conditions. They say, no, doc, I'm absolutely fine. And then he asks them about medication. Yes, I'm on metformin. I'm on ramipril. I'm on, warfarin. So people won't volunteer that information to somebody unless it's dug out. And oftentimes, if you go and see someone who isn't there to dig around about history and is there to provide therapeutic intervention, they won't ask those questions.
No, exactly.
So I think you're right. I think they are safer in your hands in that case. And I suppose going back to the original point of this Natters episode, we started out with the aim of trying to put the world to rights in terms of adjuncts, and I think we probably raised more questions than we've answered. And
that's what happens whenever we have a chat, isn't it?
Yeah, definitely. I'd love people to get involved on Twitter or Facebook, and maybe even just post some cases where they've found manual therapy to have been the pivoting factor. Someone with a 20-year history of knee pain has had some patella mobs and strapping, and all of a sudden is miraculously resolved. And not necessarily that they put it down to the adjunct, but what mechanism effect do they think is at play here? And I think that critical application of thinking is more important than whether we are directing a patella caudad or cephalad or medially or laterally in this case.
Well, I think we have sorted. Do you think we sorted out manual therapy and adjuncts, Rob?
Oh, definitely. Easily. Yeah.
Right.
Yeah.
So, no arguing about it anymore, everybody.
Yeah. People need to move forward.
Yeah.
Get over it.
We'll just post the link to this every time we see an argument.
Yeah. That's not going to happen. I'm just going to be up until the early hours of the morning as usual.
Yeah, I know. Yeah, you're the worst for it, aren't you?
Yeah.
All right. Well, thanks a lot for chatting to me, Rob.
No problems. It was a pleasure. Thanks, Jack.
See you soon. All right. Bye.
Cheers, mate.
Bye. Well, there you are. I really enjoyed my chat with Rob about adjuncts and where they fit in modern healthcare models. I do think that there will always be ends of the spectrum, but arguing about it ad nauseum with dichotomous points of view are not helping us get anywhere at this current time. I really do think our energy is better spent. Rob and I cannot help but think that there must be feedback from this episode, so please do get in contact with us. You can find us both on Twitter. I am at PhysioJack, and Rob is at Combat Sports Phys. You can also find us at TPM Podcast. If you would prefer a longer form of feedback, then email us physionatters@choosehealth.co.uk. Don't forget to listen to all the previous episodes of the Physio Natters podcast, episode 1 of Physio Natters, and look out for further projects coming up from our team. I have some fascinating guests and topics lined up for the next few sessions of Physio Natters, so don't forget to call back next month. See you all next time.